Hi, everybody. Welcome to our session on kind of how to handle type 1 diabetes in the hospital, preparing for surgeries, procedures, how to expect or what to expect in the hospital. And I'm joined by a real expert in this matter, Dr. Trish Santos. So Trish, say hi.
Hi, thanks for having me.
So a big part of Trish's job at UCSD is actually managing patients with diabetes when they're in the hospital. So we're really fortunate to have her here. And when we were kind of designing this talk, originally we had the idea of, well, maybe we could act out scenes of, what it would be like if we were in the hospital. But it just so happens that tomorrow, our good friend, Steve Edelman, is actually having a knee replacement surgery. He was in kind of a rough bicycle accident a couple months ago and had some pain. So he's getting his knee replaced tomorrow. So he was gracious enough to actually record a little video talking about preparing for this. So before we get too much further into our talk, we wanted just Steve to say hi to everybody. So Eric, roll that clip.
Hello, everybody. Steve Edelman here. Tomorrow, I am going under the knife to have a total knee replacement. I'm a little anxious, but I did everything they asked me to do. I have a good surgeon. I'm at UCSD, and my good friend Jeremy Pettis will be there if anything goes wrong. And Dr. Tricia Santos, another longtime good friend, will also be watching over me. Now, I wanted to let you know that before surgery, there's a lot of things to do so that you have a good outcome. And just real quickly, I got a bunch of blood work drawn to make sure everything was kosher. I had a stress echocardiogram to check the shape of my heart, being over 65. Sometimes they ask for that. I took an online course, what to expect before, during, and after knee surgery. I was asked to stop my aspirin. They don't want my blood too thin before going to surgery. I put ointment in my nostrils that prevent a certain type of bacteria that live there to infect my knee. Now, I'm not sure how it would get down there. I could never bend my knee close to my nose anyway. I'm too stiff. And then I'm putting on HIPAA twice a day for the last 3 days, and tonight and tomorrow morning before I go to the hospital, to make sure I'm about as clean as you can get. And then I'm going to prepare my house. I'm going to get a special ice machine that helps circulate water around my leg to prevent swelling and keep the pain down. Believe it or not, I had to borrow a walker from my girlfriend's mother. She had an extra one. They want me using a walker, not crutches. Now, there's no frickin' way I am walking in public with that walker. Crutches, no problem, but I don't want to use a walker. That's something that I have to get over. Maybe I need to see Bill Polanski and get some therapy on that. So I picked up all my pain prescriptions. I'm ready to go. And that's it. And now there's a few things I need to do at night to set my insulin pump in the right settings.
All right, so we obviously wish Steve the best. And in that opening thing, he's talking a lot about preparing specifically for a knee surgery. But obviously we want to talk about, and we will with Steve too, diabetes when it comes to surgery. So the way we're going to organize this is first talk about when going to the hospital is planned. I have a surgery on this day, a procedure on this day, and then when it's not planned. So starting with when it's planned, whether it's a procedure, surgery, what are some things you tell patients with type 1 to do, how to manage their blood sugars, all that?
Yeah, so the first and maybe most important thing is to get a robe. Like Steve had a really nice robe, keeps you comfy. No, but in all seriousness, I think, one of the things to keep in mind about these types of procedures is that, there's several different types of procedures. Could be a knee surgery, a hip surgery, could be a colonoscopy, could be a cath for, to get your heart looked at, all those sorts of things. And the people, this is not a dig, but the people who are preparing you for that procedure may not know a lot about type 1 diabetes, and they may not know the difference between type 1 and type 2. So you need to be very clear with them that you have type 1. Mm-hmm. And if they ever tell you to stop your insulin or to, take off your insulin pump the night before or those sorts of things, you want to push back. Mm-hmm. We've seen that happen, I wouldn't say commonly, but we've seen it happen over and over again, and people kind of come into a procedure and end up going into DKA.
Yeah.
So never ever stop your insulin. Never, just take off your pump the night before a surgery. Even if they tell you to, you want to ask questions, say, do you know I'm type 1? I'm not allowed to be without insulin, et cetera.
Yeah.
So really important kind of just first step.
As my blood sugar goes slightly high, but I'm okay. So, and that's important of why are we doing this talk in the first place? And yeah, I mean, the bottom line is that the hospital can be a very dangerous place, especially for people with type 1 diabetes. It wasn't that long ago that I remember reviewing our protocols for patients with coming in for colonoscopies, and it said, yeah, don't take any insulin like 12 hours before your surgery. And you might be thinking, well, they know best, they're physicians,
Right.
They're whatever, I should do what they say. But a lot of these protocols come from type 2, or they're just not appropriate for type 1. So keep your brain on. You kind of have to assume that you know more about type 1 diabetes than everybody else
I
in
would
the hospital.
definitely assume that.
Yeah. And so you said it's not a dig, but it kind of is, like
Yeah.
a little bit. You have to be on your game, be prepared. And this is unfortunate because, when you go into the hospital, it's usually a time that you're vulnerable. You want to kind of relinquish control of your diabetes. So if you can't be kind of with it, like letting other people, family members know, can't stop insulin, using CGM, all those kinds of things. So, all right, so walk us through a specific example. You mentioned colonoscopies, I think is a good thing to start with because they're so common. The prep is literally a pain. So tell us about that.
Yeah, so for any procedure that you're preparing for, just to be cautious, the risk of a low blood sugar during a procedure or kind of leading up to a procedure is more dangerous than your blood sugars running a little bit high for a day while you have a procedure, right? So
Exactly.
our kind of main goal is to avoid lows. Obviously, we don't want your blood sugar to be 400 going into a procedure, but we worry most about lows. So in general, we tell people to lower their insulin doses before surgery or before a planned procedure. So what does that mean? If you're taking multiple daily injections, then the general rule of thumb is reducing your basal insulin dose by about 20%. So you would take 80% of your usual dose. A lot of it depends on kind of how good that usual dose is, and you know yourself better, and you should kind of talk with your doctor about it. But we want you to reduce your insulin dose. If you're on a pump, these automated systems like the Tandem Control-IQ, looping, Omnipod 5, they're really keeping patients a lot safer now during these procedures, I would say, because they can, shut off insulin delivery if your blood sugar is running low. There are a few tricks with those systems. So for the Tandem system, for example, using an activity mode where, you're kind of telling your pump like it's like you're exercising, so it's aiming for a little bit higher target, is a good rule of thumb while you're kind of preparing for a procedure. If you're on Omnipod 5, you can actually change your target. So a lot of people will have their target down at 110. You can move your target up to 150 just for, the day before your procedure, et cetera. So those are the kinds of things you want to think about in terms of just aiming for a little bit higher blood sugar than you're used to, taking a little bit less insulin than you're used to.
Yeah, and the other thing that, they'll say is, don't eat after midnight after a certain period of time, which like 99 times out of 100 isn't a problem, but it's going to be that one time that you can't eat at 1 or 2 in the morning and you go low. So people say, well, what happens if I go low at 1 in the morning? What should I do?
Yeah. So that's a great question. There are a couple things you can do. You can actually chew on a few glucose tabs. So that's fine. Don't get scared that they're going to cancel your surgery. Kind of using glucose tabs to treat lows doesn't really count as food, so it doesn't really count as eating. So you can definitely, I would say, get some of those, keep them on hand. For people that are doing a colonoscopy prep, so when you're preparing for a colonoscopy, and you all should be getting those as you're supposed to for screening, they will usually tell you that you can only drink that nasty, go lightly, like giant jug of fluid, plus clear liquids. So things like, Sprite and, any kind of clear jellos, kind of non-red jellos, those kinds of things. So remember that if you're going low, you can actually drink clear liquids with carbs in them.
Right.
So instead of a diet Sprite, you could have a regular Sprite, or instead of, diet clear Jello, you could have regular clear Jello, or those kinds of things. So you are allowed to kind of, in that clears, drink carb clears. Now, the one thing I would say is during the colonoscopy prep, if you drink all carb clears, then your blood sugars are going to be high and it's going to be difficult to manage. So you kind of have to balance those.
Yeah. And I think knowing that you can treat your lows is just so helpful. A little bit of Sprite, some glucose tabs. What they're trying to avoid is somebody eating a large meal and then coming into the procedure. When you're sedated, you might vomit and what we call like aspirate something if you got all the stuff in your stomach. So just trying to keep your stomach empty, but a little bit of juice or glucose tabs like really isn't going to hurt anybody. All right, so the other thing that comes up a lot is what do I do with my diabetes technology for procedure, surgery, my CGM, my pump, meaning can I wear it during the procedure? Who do I need to tell about it? Those kinds of things.
Right. So usually each hospital system or surgical center will have their own policy about this. In general, if you're going for a minor procedure like a colonoscopy or for a relatively short surgery, most places will let you keep your pump on during the surgery. So at UCSC, for example, you're allowed to keep your pump on if the surgery is 4 hours or less, or for something like a colonoscopy. One thing you have to be careful of is if where you wear your pump is in the surgical field, then that won't work. So what that means is if you wear, if your pump infusion site is on your abdomen and you're going in for a big abdominal surgery, then you can't keep your pump on during the surgery, right? Because they're going to need to sterilize it and use that area. So you can either switch it to a new spot or just, go on injections around that time. And same thing really goes for CGM. CGM, you really can keep it on during the most procedures. There's no good reason to take it off. The people who are kind of managing your blood sugars during the procedure may have varying amounts of experience with these things. Again, you want to make sure that it's away from wherever they're operating.
Right.
So, if they're doing a procedure on, if you're having shoulder surgery and you wear your CGM on your arm, that's not going to work. You got to put it either on the other arm or a different spot for the day.
And what do you tell patients that they should give their reader to the anesthesiologist? Because, I'm just thinking about this, that for mine, it's on my phone, and after a couple minutes, it goes dead, so you give them your code. How do you do that?
Yeah, so most people don't. Back in the day when it was all on a reader, people did give their readers to the anesthesiologist, who's the person that manages these things. These days, because of the things you said on the phone, usually people it's too much of a hassle. They will still be poking your fingers to check your blood sugar. So usually that's what happens. But people still feel comfortable just having it on. Then right after the surgery, you can have it with you and not have to, wake up from sedation and put on a new sensor. That's kind of a pain.
Right. And when they don't do that, they generally will check your finger like every hour or so.
And it's also good, sorry to just finish up, it's also good to leave your CGM on regardless of if they're looking on it, if you're on one of these automated systems and you're wearing your pump, because then it still needs to talk.
Right.
So important not to remove it.
And then important, maybe to keep your cell phone with you too, just let them know that they can take it in or something so it's reading.
Right.
All right, so Steve didn't hear any of this before, preparing for his surgery tomorrow. So he sent us a little video that we haven't seen on what he's going to do for his surgery. So as it pertains to blood sugars and his pump and all that. So let's hear what Steve has to say there.
Okay, believe it or not, it's close to midnight. I'm scared to death. And after midnight, I'm not supposed to drink or eat a single thing. They don't want you to do that. So at 11:59, we're going to have a big swig of this. No, I'm not. I'm kidding. Drinking hard alcohol or any alcohol the day before surgery is probably not advised. Now, here's the most important thing I want to tell you. I use an insulin pump. I have a Dexcom, continuous glucose monitor. I have an Eversense implantable CGM. That's my transmitter. I got 2 sources of numbers, and I'm going to bring my Dexcom reader to the hospital and let the anesthesiologist have it and look at my numbers during surgery. Now, here's the important thing. I use a hybrid closed loop system. I'm going to put my system in activity mode, which means it shoots for a blood sugar between 150 and 160. I'm going to do that starting now, the night before. So when I cruise to the hospital tomorrow, my blood sugar will be cruising somewhere between 150 and 160. It's very accurate. And so this is important. Most surgeons, anesthesiologists freak out when they see a blood sugar 110, which is what my system usually shoots for. So 140 to 180 is kind of a good range. And also I will educate the anesthesiologist about trend arrows. And that's it. Wish me luck, and I'll see you on the other side.
So I think a lot of similarities. He was basically saying, with putting it in activity mode or exercise mode, that you're targeting that slightly higher blood sugar, that you're permitting a little bit of higher blood sugars, with the importance being on avoiding the lows. Right. I think was kind of a message, which, by the way, is which I always tell people for alcohol. Anytime you're in a situation that might be a little bit different, that you can prioritize avoiding those lows, because those are the things that'll get you in the short term, allow a little bit of higher blood sugars.
For sure.
Yeah. Okay. So that is in the world of things that you can plan for. I got my surgery in 6 weeks. You can think about it for a long time. Again, what you do a lot of is somebody's admitted for pneumonia or heart failure or whatever it is, and they also happen to have diabetes. What does that look like? Because again, that's a time where patients really scared. They're probably not thinking about their blood sugars. Their blood sugars might be a mess because they're stressed, et cetera. So walk us through what diabetes is like, especially type 1 diabetes in the hospital, and how patients can stay safe.
Yeah. So, first off, again, I would say anytime you're going into a hospital situation, you really want to advocate for yourself. You want to tell everybody that you have type 1. This is not type 2. I can't be without insulin. If you're, somebody took off your pump because you're going to an MRI, you need to say, hey, I don't have any basal insulin on board. Like, you really need to advocate for yourself. When you go to the hospital, I would say, if you are kind of awake and coherent, and this isn't like an emergency situation, and you're going into the hospital, some things that you can do to prepare are, if you are wearing a CGM and or a pump, which I think these days a lot of patients are, you want to bring your stuff with you. Mm-hmm. So you want to bring your pump supplies with you, extra infusion sets, extra sensors, transmitters, hopefully not for long. We won't have to deal with transmitters. But those sorts of things, because if you do want to use the technology in the hospital is not stocked with infusion sets. Mm-hmm. So that's not a thing. They're not stocked with, extra CGM sensors. So sometimes, we'll have little samples of those things, but you definitely can't count on it.
Okay. And then walk us through, let's say I was admitted, my hybrid closed loop system. Hospitals are different. At UCSD, are they going to take off my pump? Are they going to, allow me to use it? Does that change hospital to hospital? How should people be worried if they're taking away their pump?
So it's important to understand that right now, continuous glucose monitors are not FDA approved to use in the hospital. So I always say yet, because I really think this is coming very soon, that we'll be allowed to use them in the hospital. But what that means for you is, in most hospitals, you're allowed to keep your CGM on, but they still have to poke your finger 4 times a day at a minimum, which is really frustrating for those of you that have been on sensors for a long time now and aren't doing that. But they're not trying to torture you. It's just what's allowed. Right. Okay. That being said, hospitals also have different policies on pumps. So at our hospital, you are allowed to wear your insulin pump. You got to sign a little contract saying that you'll you know how to kind of adjust your insulin and count your carbs and dose for carbs and those sorts of things. But the criteria really are that you are kind of awake and alert enough. So if you're in the hospital and you are feeling really, really crummy when you get there, you really should tell someone, hey, I've got this pump on and I don't think I can manage it right now, if there's something that you really need to manage. Now, if it's one of these automated systems that's kind of doing its thing and you're not really eating, then maybe not a big deal. But if it's something where, you have to change your site tomorrow and you're really not kind of alert and able to do that, then you want to let someone know that you're not up for it. Most hospital systems will let you wear your pump during the hospitalization. One thing I would be very clear about telling the doctors and nurses that you're working with is the difference. You'd be surprised. They don't all know the difference between a pump and a CGM. So they may think that your CGM is delivering insulin or that your pump is doing everything and you don't need to do one thing to it, so you have to be very clear about that. And if they're trying to take it off, you can advocate for yourself and say, I'd like to talk to the specialist, tell me why you're trying to take it off because I'd like to wear it during the hospitalization. It's okay to kind of advocate before just automatically removing it.
And so that's kind of my next question. So let's say that for whatever reason you can't manage your pump or you're sick. Who takes over your insulin dosing?
Yeah.
Who manages your diabetes?
Right. So this is highly variable by hospital at this point. So at our hospital at UCSD, we have an entire team of doctors and nurses and diabetes educators who are very well versed in type 1 and able to kind of care for all of our patients with type 1 that come into the hospital. Some hospital systems don't have kind of endocrinologists or diabetes specialists. So you may be advocating for yourself more than you think. Mm-hmm. You know, one thing to keep in mind also when you come into the hospital is that people may be recommending kind of things that are a little bit different than you're used to. So they may recommend a little less basal insulin than you're used to if you're off of your pump, for example. And sometimes this can be really terrifying, I think, to have someone else kind of take control of your diabetes. But you have to recognize that in the hospital, there's several variables that are really changing. So one, you're probably, you know, a lot less active than you're used to. For most people, the diet and carb intake in the hospital is significantly different than what they're eating at home. Infections that you may have or other stress on your body can make your blood sugars higher than you're used to. So there's all these changing variables. Mm-hmm. So people, just be aware that people may recommend kind of different doses than you're used to. They're not trying to harm you, but, and it's okay to advocate for that a little bit, but if you have a little bit of disagreement on the dosing, you know, don't freak out.
Yeah. So we talked a little bit about the goals for procedures to avoid hypoglycemia, because it's usually a short thing, a couple hours. But when you're in the hospital, you know, days, weeks, we know that controlling your blood sugars helps with, you know, recovery from infections and healing, and like, so you don't want to just kind of let your blood sugars go. So what is your goals when you're seeing somebody with diabetes in the hospital? Where are you trying to keep their blood sugars?
Yeah, that's a really good question. So in the hospital, kind of the general range of goals is about a glucose of 100 to 180. And this can be very different for some people. Like some people are used to having their blood sugars, you know, never go above 120 or something, right? And so recognizing that one of the reasons we don't aim for them to be too low is that things can change really quickly in the hospital. For example, they could say, oh, something changed with your medical care. All of a sudden you're not allowed to eat, you know, and you may have planned on kind of snacking all day and using up that insulin, but all of a sudden you're not going to be able to eat. So really we have kind of that wider range just to keep people safe. That's our main goal, keep people safe and improve kind of wound healing, infection healing, all those sorts of things.
Yeah. So there's definitely some people that will seem higher than they're used to, but there's also the opposite. I can think of a couple of patients that it's actually been a positive. One patient in particular that I could never get him like in control. His blood sugars average was usually 300. He was in the hospital for a while and kind of got the carb counting and like, you know, like that down, and just, it really changed his life. He was admitted for something completely different. Infection was there for a long time. And do you see that where like there's an opportunity for kind of education for people that, I don't know, might be struggling with their diabetes?
All the time. And we also see people who, like you mentioned, you know, their blood sugars are, you know, at home are in the 300s, 400s most of the time. And it's very nice in a controlled setting in the hospital when we can give them a specific dose of insulin and match it to the carbs that they're eating. And then they realize, hey, this works, you know, and I think it's a big eye opener for a lot of people. Yeah, for sure.
So, you know, maybe it's worth talking about a little bit too, like some of the real curveballs you see in the hospital. And the one that comes to mind, you mentioned all the things that are changing, is steroids. And I'm not talking about testosterone and the pump-up steroids. It's the anti-inflammatory prednisone, cortisone, things that we use for all types of things. We give it with chemotherapy now. We give it with like intense inflammation. And they wreak havoc on blood sugars. Not just in the hospital, but if you've ever been on a prednisone taper for a back or knee injury, general advice you give type 1s with this? Yeah,
so that is a huge problem. And like you said, steroids are like a wonder drug. They really are. And they also happen to have some of the worst side effects, one being difficult to manage your blood sugars. And in the hospital now, we're also seeing a lot of steroids for surgeries, believe it or not. So same-day surgeries, they're giving kind of a slug of dexamethasone would be the steroid to look out for.
Like knee surgery?
Yeah.
Really?
Yes, knee, hip surgeries, yes, because it helps with nausea. It's a huge anti-nausea medicine, which during the anesthesia, that can cause nausea. And so they're giving it often.
A great point that Steve might have no idea that even like they're thinking that way. And often they don't ask.
Correct.
You know, can we give you steroids? And in fact, I don't think they ever ask.
And it's usually done intraoperatively, which means while the patient is under anesthesia in the OR. So when you come out and you get a list of medicines that you're going home with, the steroid's not going to be on there. So if your blood sugars are high out of nowhere, that may be something to look for. In general, patients usually need at least at the very minimum kind of a 20% increase in especially their mealtime dose of insulin. Sometimes it doesn't affect the basal as much, but certainly needing to go up on that carb ratio and correction factor for sure.
Yep.
Yeah, sometimes they need, 5 times the amount of insulin. I mean, it can be a lot.
And that's another thing, is that it's very dose dependent, and the doses of steroids we give are very variable. And almost always we not almost always, but a lot of times we titrate it down. So every day is like literally a different day. So you might need 2-3 times as much insulin. A good thing is it does make it harder to go low. So you do your best, but if you're keeping your blood sugars around 200 when you're on a significant dose of steroids, for me, that's pretty good. Yeah. You want to avoid the 300s and kind of higher. But that's something, what do you tell patients, like I'm just off the cuff now, they're getting just a knee injection for steroids or something kind of in a joint?
Yeah, so injections in a joint, it can even happen with inhaled steroids for certain respiratory illnesses and things. I would say in general, the injections in joints, I feel like for my patients are usually absorbed into their system. They usually don't go kind of unnoticed. And the injections in the joints, usually I'll tell people to increase their doses. I'll start with 20%. And then usually they'll have to do that for about 5 to 7 days, sometimes longer, sometimes less. It depends on kind of the dose, where it went. I find the spine injections to last a little bit longer sometimes. So yeah, steroids can wreak havoc, but man, do they make your joints feel better.
Well, I think we need to definitely call Steve and make sure that he knows about, not to make sure if he knows he's getting steroids or not. But I don't know, any kind of closing thoughts you want to leave people with? Or?
I mean, I think the one thing we kind of didn't touch on was what to do if you're at home and you're sick.
Yeah.
And I think most of you probably know this just by trial and error and having colds and the flu and COVID all these days. But just remember that whenever you have a bad cold or flu or those sorts of things, it can really also wreak havoc on your blood sugars. And kind of 2 things can happen. Number one, the infection itself and the stress hormones can raise your blood sugar quite a bit. So some people will find that they need to just give more correction doses, throughout the day, or increase their insulin doses by 20% or so. But then also it depends on, if you're really sick and you're not eating, then that can, sometimes mean you need less insulin. So it can be tricky, and I would just say pay attention and don't stop taking insulin.
Yeah,
because
absolutely.
We do see patients come into the hospital with DKA who said, oh, I wasn't feeling well and my blood sugars were kind of running low, so I just stopped taking my insulin, or I turned off my pump or something.
Yeah.
And that's where you can run into trouble.
Yeah, and obviously this came up a lot with COVID, where people with type 1 were getting COVID and they said, I'm home, when do I need to go to the hospital? And what should I do with my blood sugars? Really, there was nothing special when it came to COVID in terms of blood sugars. Keep an eye on them. Generally, people need more insulin because they're stressed. Not aiming for perfect, just kind of keep it like reasonably controlled, and things kind of do improve. But yeah, sick day rules is just generally more insulin, staying hydrated. Anytime you can't keep food down, you're vomiting, that's when you really need to think about going to the emergency room, because the concern is, what if you go low and you can't kind of take in food? But the kind of take-home messages here is being prepared, being educated. The more you know about this, the more you can kind of anticipate what might go on in the hospital, the better. And generally people do well, but the more that they have this knowledge, the more that they're already kind of anticipating what they're going to do with their pump, CGM, et cetera, the better people do.
For sure. And just, understanding that things change a lot in the hospital. Yeah. There's so many different variables, your kidney function, your whether you're eating, whether you're not, your activity, all these things, your blood sugars may not look the same with the same amount of insulin as they do on the outside.
Well, good luck, Steve. We'll be wishing him the best. Thank you, Trish, for doing this talk.
Thanks for having me.
And hope you guys enjoyed it.